All right, so welcome everyone to this webinar on delivery practice in schema therapy. We are very, very happy to be hosting this webinar with our colleagues Wendy Bahari and Joan Farrell, who I'll introduce in just a minute. My name is Alex Vaz. I'm with my wonderful colleague and partner in crime, Tony Rumenaire. We are writers and researchers on delivery practice. And Tony, I think you want to say just a few words of our sponsor.
Yeah, so Alex and I are with the Sentio Counseling Center, where we provide low-fee therapy for California residents. We also do intensive training for supervisors. So if you're interested in that, please visit us at this website. Thanks, Alex.
Great. All right, so let's jump right into it. I want to introduce our wonderful guest expert for today. So with us is Wendy and Joan. So Wendy is the founder and director of the Cognitive Therapy Center of New Jersey and the Schema Therapy Institutes in New Jersey, New York City, and DC. She is past president of the International Society of Schema Therapy, and she's the author of Disarming the Narcissist. And for over 20 years, she has been lecturing internationally to professional and general audiences on schema therapy and on narcissism and relationships. And also with us is Joan Farrell, who is a clinical psychologist and adjunct professor of psychology and research director of the Center for Borderline Personality Disorder Treatment and Research at Indiana University, Purdue. She directs the Schema Therapy Institute, Midwest Indianapolis. She has been training psychologists and psychotherapists internationally for over 40 years, and she has developed a group therapy model of schema therapy with Ida Shaw. And she wrote 2 books on this group therapy model for borderline and other personality disorders. I could go on, but for just the time we have for today, I just want to welcome you both. Hi, Wendy. Hi, Joan.
Hi, Alex. Tony, thank you.
Glad to be here.
Hi, everyone.
Yeah.
We'll
be jumping in just a minute to the real meat of today, but before I want to give just a single slide that I think summarizes kind of why we're here, just a very big picture idea. So we make this distinction in the psychotherapy literature, but more importantly, just the learning and training literature makes this distinction between conceptual learning or conceptual training and procedural learning or procedural training. So conceptual learning is anything that you learn through reflective means. You could be reading a book, you could be attending a lecture, hearing us talk or yak about something. You could watch videos, and conceptual learning is really helpful to learn theory, to learn about the history of something, for example, a psychotherapy model. And as I think, if you may reflect back on your own training experiences, you'll probably find out that most of your psychotherapy training in graduate programs and beyond mostly focus on conceptual learning. So learning through reflection and talking about or reading about something. Now, that is different from procedural learning, which you could say is learning by doing, right? Behind me, I think you can see I have a bunch of musical instruments. So imagine if I go to my piano teacher and all I do with my piano teacher is discuss the history of the piano. That would be really interesting, and I could learn about the theory of the piano and the history of the piano, but that's very different from actually learning by playing the piano and getting feedback on my performance. So we're taking this idea from the science of expertise and research on training into the field of psychotherapy. How can we also create resources for therapists' procedural learning? And that's the whole idea behind delivery practice, is not just thinking about theory or talking about theory, but also really practicing skills repeatedly and getting feedback on your performance so you can get better and better over time, like you would with any sport or musical instrument. So we've been doing this book series for the American Psychological Association. Tony and myself are editing this book series, and we have the great luxury of working with top trainers from all of these different therapy models you're seeing on the screen. This is actually just a sample of the books we're working on or have worked on. We're up to a lot of books at this point. And the gist of it is we focus on a therapy model. We work with a renowned trainer or trainers from that model, and we try to create deliberate practice exercises or skill building exercises that professionals, trainees, trainers can use to get progressively better at a single skill, right? So think of it as micro skills training, right? So very concrete skills training so you can really feel your competency going up over time. And we had the great luck of doing a book for schema therapy, deliver practice in schema therapy, which is, of course, where Joan and Wendy comes in. I think, correct me if I'm wrong, Randy, we first were able to reach out to you, and then you immediately said that Joan would be the ideal partner in crime. Is that correct?
That is correct, yes.
Great. So I think before we jump into the actual kind of contents of the book, I wanted to throw a larger question to Joan and Wendy. And that question is, why is deliver practice relevant for schema therapy? What does it bring to schema therapy training?
Well, there's already in schema therapy, there was a tradition of practice and some research suggesting that therapists who have a predominantly practice approach, or at least a divided practice and didactic approach, have better outcomes. And so this idea of micro skills and further practice and very strategic practice fit perfectly into the existing approach of schema therapy. And it's been able to expand it, I think, as far as Wendy and I view it.
Yeah. And our trainings are inclusive of practice always, working towards capacity to be rated for competence. I think this is going to, deliberate practice and these micro skills now being integrated into our training programs is really going to be a gift in expanding our capacity to enable clinicians to really have a good eye on, as they practice these skills, a good eye on competence and the evolution of that competence, as you mentioned, Alex. I think that's the beauty of it. It's a complex model, but I do think that this will lend itself to making it more accessible.
Yeah. So speaking to the complexity of the model, one of the challenges I know that you faced was this kind of Herculean task of being able to chunk down the model into specific micro skills. Could you tell us a little bit about this process of trying to figure out which skills should go into the book? Because I imagine you could write free handbooks of micro skills for schema therapy.
Yeah, easily. We could have done three handbooks. Joan and I talk about it all the time, right?
Yeah. And we started looking at the competency rating scale because fortunately we have that to go back to in schema therapy. But then we realized that we needed more in a sense, and there were different aspects maybe we would focus on. I think a way that I kind of think about schema therapy is that there are four main components. That, there's the emotional, the mode awareness part, the mode management part, mode healing, and limited reparenting. And so we discussed that a lot and came up with what we thought were the main components. And I think in the beginning, whenever we would choose what we thought was a micro skill, you and Tony would tell us that there were maybe 3 or 4 micro skills within that skill. And so we kind of got it in terms of the idea of what a micro skill actually was. And, we went through all kinds of lists and narrowing down the lists and debating inclusion, but we ended up with, yeah.
We role played a lot of it. I think that's what was really helpful because Joan and I are pretty good at kind of sitting there and going right into a role play, and that helped. But again, it was difficult, as you just mentioned, Joan, to consider, how do we leave this out? This is so important. And, once it was done, it just made sense.
Yeah, I think also we realized that we needed to stay with kind of the core or basic skills. We could go from beginner to intermediate to advanced, which we really liked about your approach and deliberate practice, but we couldn't take on the most advanced aspects of schema therapy. We need another book for that.
Yes.
And we're ready.
We're ready.
We hear you loud and clear. I'm curious about your perspective on this. What we have found is that even if we do stick with quote unquote basic or more kind of initial skills from the model, therapists often and trainees often have a good cognitive understanding of these skills, but when you actually see them doing it, that's quite a different picture. So we want to talk about it because some people might think, well, I already know this beginner skill. I don't need to practice this. But there is this gap between cognitive understanding and being able to actually do it with a client. Could you talk a little bit about that gap?
Well, it's that thing we call actually, showing up and applying the strategy, which includes everything from your facial gestures, your eye contact, your tone of voice, your body posture, the word crafting. So you may understand, as you were pointing out, conceptual versus procedural learning, Alex, there is, you have a basic concept of what's to be done and what you're trying to achieve, what your mission is, what your destination looks like. But getting there is very different, which means really, how you show up as the therapist and how you select those words that are going to be most meaningful, where the emphasis will be placed to touch someone in a way that meets that need.
I think too, as an advanced schema therapist, it still was helpful to keep in mind the criteria of the particular skills. And I found myself that it was interesting to be reminded of all the different aspects that go into this one kind of intervention, and that I might not have necessarily thought about. So I found that the practice, I think, improved my skills also. And just with Wendy and I going back and forth and talking about different words, succinct versus elaborated, I mean, a lot of that was, I think, also advanced and added to my skill as a clinician. So I think it is valuable for beginners and for advanced therapists. It's just maybe different things are possible, whatever level you're at.
We actually presented this in Copenhagen at the conference last June, and we had master clinicians in schema therapy in our audience, and a mix of people at different levels, but even master clinicians were quick to give us very positive feedback about how it just reminded them to be aware. They felt themselves sort of working in slow motion and recognizing the value of seeing the way they were showing up and the words that they were choosing. And as Joan just pointed out, like, is it meeting that criteria 1, 2, 3? Right?
Yeah.
I think also getting very refined feedback from someone playing the client when you vary something about your presentation, that's so helpful, because that's a piece that we, particularly more advanced clinicians, don't get anymore, because we're not doing like intervision. Maybe Wendy and I do a lot of it in our online community, but for most people that kind of has gone by the wayside more, and I think that's quite valuable.
Field practice kind of gives that opportunity to get immediate feedback, right?
Yeah.
So I think for everyone hearing there, I'm sure curious about which skills actually made it into the book. So this is the list of all 12 exercises or schema therapy skills that are in the book. You want to walk us through a little bit your rationale for these skills and how you put together kind of the structure?
Yeah. We can do this together, Joan, if you want to start.
Sure. Well, understanding and attunement, of course, is necessary but not sufficient, maybe, skill in schema therapy. And the second exercise is supporting and strengthening the healthy adult mode, but that tends to come a bit later, maybe, in terms of the process or throughout.
Yeah, and education, of course, that ability to be, I think one of the things I've always loved about the model is that transparency, and that how quickly we move to make sense out of the current problem and how it's related to what's happened in early life experiences. So, we move to schema therapy terms pretty quickly to make the sessions meaningful.
I think that's particularly helpful when you're talking about people with severe personality disorders, particularly my population was often borderline personality disorder, and it's a very non-pathologizing approach.
Yeah.
But the education is very important so the client can collaborate with us.
Yeah.
Yeah, it's interesting. There's a number of, you could call it psychoeducation skills, right? I mean, schema education, linking unmet needs, schema and presenting problem, educating on modes.
Yeah.
And then there's what you might call, it's still a form of education, but it's more experiential. It's like catching things in the moment, right? So recognizing mode shifts, identifying modes. Yeah. What was it like writing these ones and the thoughts behind these?
Well, that's,
I mean, they make sense. These are, you know, as Joan and I have discussed together, these are the heart and soul of schema therapy. And they are, I think you said, we were saying this yesterday in a conversation, Joan, these are distinctive features of schema therapy, is how we really look at these very present moment shifts in the way one is showing up, how they're shifting between these various states of mind or parts of self or coping modes in this case, and how we work to do the limited reparenting in order to connect with that vulnerability when modes are present.
Yeah, I think also this is a particular skill that I cover a lot in doing supervision. And I think seeing it here kind of concretized and focused on in this way, I think will be so helpful for schema therapists just to think about. I mean, I'm very alert to any kind of shift and wanting to inquire about it. And initially, clients don't have awareness of modes, but we're having to point it out to them. And then afterwards, they can begin to have that awareness.
I think what really became illuminated for me, Alex, in this practice is Joan and I would role play, and then we'd start to put the words on paper. And of course, Joan is so good at putting them in the boxes, and I'm so bad at narrowing the language down. But we were a good team in that regard. What became so clear and illustrative is that, you know, one of the challenges for all of us as early clinicians is being present in the session, you know, really being part of the conversation, not just delivering information, but experiencing it alongside our clients. And being able to notice means I'm noticing you shifted. I'm noticing, did you notice something different? We're very present with the client. And that's something that just kind of really got spotlighted for me in writing this.
Yeah, because I imagine in doing the deliberate practice exercises, you're giving repeated opportunities for people to train that skill, right? To actually catch things in the moment, right? Because I guess a lot of people here could give a really good kind of write a good paper on what modes are and schemas are, right? But I speak for myself, it's harder for me to then actually do it with a client, right?
And could actually educate their clients about that, but not necessarily be present with them in the identification of it when it's showing up. And I think that's really distinctly different. And when we practice deliberate skills, as you said, one of the things that I'm going to immediately start adding to my own training is that the person playing the client is giving feedback, not just the supervisor who's overseeing the practice exercise, but that the client is giving feedback.
I think a major thing I noticed too is that this gives the deliberate practice approach gives people a way to have some of these things become automatic. They notice a shift, and even I often say something happened right now. What are you aware of? So I think that a lot of what is schema therapy becomes more just automatic for people.
Yeah, we use that expression, muscle memory, right?
Yeah.
So it's interesting. This book is divided roughly into beginner, intermediate, and harder skills, more advanced skills. And we see down below here, we have the limited reparenting skills right at the end, right? Which again is a staple of the model. But I've known my own trainees saying, well, it sounds really good, but how do you do it? Right? So then having to make this more concrete, again, a new challenge. I'm sure people are curious how this is actually broken down into, right? And go ahead, John.
Well, I think we did it by mode because really the different modes, I mean, first you need to identify the mode, and that's what came before. And then once you have, what's needed for the vulnerable child is more, I mean, it's always about meeting needs, but the needs of a child are different than the needs of a person in a critic mode or in a coping mode. So basically, we divided the different skills of limited reparenting and matched them up with the modes that are present.
Of course, we're always giving consideration to the underlying schemas, because the schemas will inform the needs. So the modes make sense once we understand schemas. I always feel like I have to say that out loud, because yes, we have a beautiful mode model, but early maladaptive schemas are still the very traits that inform us of the needs. And so, we identify these schemas so that our navigational tools, which are the needs, make sense when we see someone moving into a critic mode or a detached protector mode. Right. And I think we were keenly reminded of that, as Joan just said, as we were beginning to think through how do we begin a process of limited reparenting, which is meeting needs within each of these modes.
I remember early on, Tony and I, one of the suggestions we gave as we were starting to pick the skills, or you were starting to pick the skills, was focusing on skills that most trainees had difficulty doing. They might cognitively understand but had difficulty doing. And one of the skills that I know you're particularly fond of that we focused on is exercise 11, empathic confrontation. And you guys chose that skill to give people, our attendees today, a taste of the lower practice exercise. So I'd like to ask you if you could just give a primer on why this is such a relevant skill, and why do you think trainees have a hard time doing this skill in actual practice?
I think, it's one of my favorite skills, and that's clear to most people who know me, because I work with the population of people with issues of narcissism and narcissistic personality disorder. But empathic confrontation is used in all of the types of clients that we work with in schema therapy. I often think of it as it's almost a posture. It's a part of the way we show up, being empathically curious, empathically attuned, empathically resonating with what one is experiencing, and confronting modes that are getting in the way of our connection to that vulnerable child in order to meet needs. So it's not just limited to working with difficult people like narcissists. It's something we would use with so many of the more challenging modes, including the detached protector, which is one of the most challenging, the avoidance issue. So, that was part of the reason we chose it. But I think empathy gets confused often with sympathy. And so it's that sense of being in a state of just understanding, but also being able to see the high price that's being paid for being stuck in a mode or surrendering to a mode, as opposed to being able to allow us to facilitate a process for bypassing it.
Yeah, I think too, I agree that it's very important. And I think particularly it's one of the reasons that schema therapy is demonstrating so much effectiveness with people with personality disorders, because clearly in that situation, there is some problematic behavior that's interfering with getting people's needs met. And the therapist people in their general life are not going to give them constructive feedback about these behaviors. So as therapists, the buck stops here in a way. We need to give them that feedback, but we need to maintain our connection with them. And empathic confrontation is a way to do both of those things. And it also clarifies our intention, that we're giving them this feedback because we see it as interfering with needs met. Yeah. And that's problematic. It helps us avoid that experience with rejection sensitive borderline patients that we're saying in some way they're bad, or people with a defectiveness schema that our criticism is damning in some way. It's operational, and it's also done in a way that is as little critical as possible, unless it's the kind of mode that also needs some limit setting, like the bully attack mode.
And it reminds me, Alex, going back to your question of why did we choose it and why do we see it as one that's so hard for clinicians to practice? I think, it makes me think about another book, which might be Self-Practice and Self-Reflection and Deliberate Practice. But I think it's because the word or the thought of confrontation, confronting someone about a negative effect or something that might seem pejorative can be scary. The idea of confrontation and the kind of kickback that we might get from a client who's in a more agitated, detached state or an angry, protective state, that who wants to feel that? Who wants to be judged or criticized, right? So it can be difficult, and I think again it calls for us to be in as sturdy a self as possible, our own sturdy, healthy adult modes.
The one thing I'm picking up on what you're saying is that you could see empathic confrontation as a way of being, a stance, but there's definitely also a way of doing, actual therapist behaviors that can be practiced towards the end of doing empathic confrontation, right?
Yes.
And in this book, of course, we want to be mindful of that way of being, but we also want to give people opportunity to practice the behaviors, right? So let's actually show people what it looks like, the little practice exercise. So again, this is limited reparenting for the maladaptive coping modes, the empathic confrontation exercise. And so Joan and Wendy did this very hard task, but I think very worthwhile, to dissect the skill into very concrete, observable therapist behaviors that can be practiced, right? So for this skill, we divided it into 3 skill criteria, which are these 3 numbered statements here. So to do an empathic confrontation, the therapist first points out in a warm, non-critical way how a coping mode behavior is problematic because it does not get the client's need met. Then the therapist communicates an understanding that this is a leftover survival response from childhood when a core need was not met. And finally, the therapist suggests an alternative behavior is needed to get the client's need met. Right? So notice, this is chunking down this, you could call it a more broad idea of doing an empathic confrontation into very observable therapist behaviors that can be practiced, right? And you can practice all 3 of these or in isolation. But for the purpose of this practice, every therapist response should try to meet these 3 criteria, right? So let's actually try doing it together. We're going to invite our wonderful attendees here to try this little practice exercise. Normally, we would be doing this in a role play fashion. And here, because we have so many people all around the world, we're going to take the opportunity to get everyone involved. So all of you who'd like to actually practice the skill, we're going to be using the Zoom chat to practice a little bit. First, we'll be giving just an example of what this skill looks like. So let's imagine, for example, that the client says, I felt really sad and shed a few tears when my friend called last minute and canceled our plans. I don't know why I'm reacting so much. It's really not a big deal at all. Therapist could respond, when you feel something painful like sadness and then quickly question your feelings and minimize them, you're cutting off important information about what you need. So that fulfills criteria 1. Point out in a warm, non-critical way how a coping mode behavior is problematic because it doesn't get the client's needs met. The therapist continues and says, I know this is a coping response from childhood when your feelings were criticized or minimized, which meets criteria 2. Finally, but you need to take your sadness seriously and explore what it communicates to you about what you need, which meets criteria 3. Suggest an alternative behavior is needed to get the client's need met. So there's quite a bit in here, right? But let's try it. Let's try it together. We'll do a practice. And as luck would have it, we have 2 expert schema therapists with us who can provide very compassionate, warm, non-critical feedback. So what we're going to suggest is we have a new client statement here. And to anyone who wants to try it out, write on the Zoom chat a therapist response that you think would meet the 3 criteria, the 3 skill criteria. So the client statement is, I never felt loved as a child or that I mattered to anyone. Is that what you asked me about? My mind just went blank. Okay. So let's give people a minute and try writing a response that meets the 3 criteria.
Hey, we've got Wendy and Joan, we've got our first reply in the chat. I'm just going to read it out loud so everyone can hear it. I'm going to read it slowly. I noticed there that as you touched on how difficult things were for you as a child, you went into detached protector mode.
But that's the beginning.
Yeah.
That's criterion 1, right? And you would need to go on from there to hit, it's conveyed somewhat by labeling it as detached protector, but some understanding that this was a way that they coped in childhood when a core need wasn't met, and the alternative behavior would need to be added.
Great. So this was accurate for the first skill criteria. Great. Here's another one.
I think number 2, Tony, is below.
Oh, it just appeared. Okay.
Yeah.
Number 2, I realize you learned to do that as a child to protect yourself from painful feelings. How's that?
That's good. That's great, actually. There's the identification, there's the link, but now we need the confrontation, which is pointing out how this is either a problem or suggesting another way that they might be able to bypass that mode.
Great. I'm going to read the next one. It's by Wendy. If you scroll up just a little in the chat. I wonder if your mind goes blank when you're in detached protector mode. This is sometimes a survival response left over from a time in life when our needs were not met. Perhaps we can try just sitting with this for a moment and seeing if we can identify what you're feeling right now.
Yeah, I like it. Can you see that, Joan? That's
yeah. I'm just thinking for the sake of instruction. Okay, I might be less tentative about it. I mean, we want to be non-critical and personal, but I would probably be a little more direct in saying, I think that your mind going blank indicates that this is a difficult topic for you and that there's an important underlying need. I would be probably less interested right now or with this skill in labeling the mode.
Unless it's assessment. So I would say only if this were just assessment and you don't know enough yet about the client, then I like the idea of wondering out loud with someone. But so I guess we should decide, Alex, if this is assessment versus we already know enough about the client in the response. I'd agree with Joan. I would be more definitive about what I see. But if it's assessment and you're really trying to conceptualize together, I wonder if your mind goes blank when you're in the detached protector mode, or we might call this a detached protector mode, and then talk about how it can be a survival response and make a suggestion for an alternate behavior.
Great.
And I think the suggestion for an alternate behavior is good.
Yeah.
I guess what I'm saying too about being a little more definite and personal, probably rather than saying this is sometimes a survival response, which is kind of educational, I would probably suggest more, I think that this is the way you survived as a child when your needs were.
So using the word you to really anchor it in the client.
Yeah, rather than the more general educational kind of tone. Just because I think that warmth and being personal is such an important part of empathic confrontation.
Yeah.
Got it.
Unless you're setting limits, which this isn't, that's not this exercise.
Right. We'll see that, I think, in a later one.
Yeah. I think if you scroll down to Francesca too, you'll see. I mean, I think there's a...
Here, let me read Francesca's out loud so everyone hears. When you feel unloved or unimportant, it is easy to blank out. You may have learned that as a coping response growing up with such busy parents as yours. Perhaps next time you can ask your partner to recognize your need to matter and be included.
Mhm. Yeah.
So pitching it even more specifically, assuming some additional information. Yeah, that's good.
I like it.
Great. So that response included the you, it's really anchored in the client. And you can kind of feel some empathy in that.
Mhm.
Yeah.
I'm going to read the one a little higher from Nina Jukara.
Yeah.
Do you notice that you just bypass so quickly your needs? It is very understandable as we know your childhood and how your parents neglected your emotions and needs. But is it necessary for you to practice a new way for you to be there, that your needs and connections, your need for connection will be met?
Mm-hmm.
I'm just thinking for the last part, again, I wouldn't make it as conditional, the suggestion of a new behavior. I think it's okay to say with this sort of behavior, with the coping mode, quite definitely, a different behavior is needed. So it's just a question of changing it from the conditional. And I think this is something therapists kind of struggle with, how kind of definite to be with some of these statements.
I think this one actually is, though, isn't it, Joan? When she says it is necessary for you to practice a new way to be there so that your need for connection will be met. So I think maybe I'm just hearing it differently.
Or maybe I didn't read it right.
It could be just in the way it's worded, but noticing so quickly that you just bypassed your needs. It's understandable. We know your parents neglected your emotions, but it is necessary that you practice new ways to be there for your need for connection to be met. And then, of course, you'd want to give examples of how they're going to do that. We don't want to leave them stranded without some information about how they might do that. We want to actually, demonstrate, show them, practice with them ways that they can maintain, their own sense of advocacy, even though it will be hard.
Great. I'm going to read the one below from Ruth.
Mm-hmm.
I recognize that this is a tough topic to talk about. I can imagine that balancing was a way to survive in your life. But now I would like you to stay here in the room so we can change your response and help your inner child.
I would probably want to be a little more specific for the first criteria. I recognize it's a tough topic. I think that's caused your mind to go blank. I think probably moving away from painful emotion or painful topics was a way you survived. But it's important today to be able to be aware of your feelings and needs, so that we can define a behavior to meet them. I think I wouldn't throw in the inner child exactly now, but this is just, again, I'm being kind of specific about it.
Now, Joan, would you, and Wendy, would you agree that Ruth's response is kind of ballpark correct, and you're providing, ways to kind of sharpen it, right?
Oh yeah.
So
absolutely. Yeah, definitely.
Absolutely. Because I could imagine saying something like this, Ruth. I'd say, look, these are tough topics to talk about. And, given what you have lived with, the challenges of trying to survive in a home where, sharing things that are painful is dismissed. I'm just making this up, right? Are dismissed so easily. There's no space for your voice. I get it, right? But now I'd really like to try to help you to stay with me with this, because without that, so there's a reason, right? What's the reason? Because without that, it's going to be very hard to get those needs met for connection that you're looking for, that you've come here for, that we've agreed are so important to you, right? So we're making the case for why, right? For why that's important. to them in the alternative response, like why the alternative response is important, even more so than what exactly that's going to look like when we do it.
I'd like to highlight something, which is so far all the responses we've gotten, I think, are pretty obviously from people who know schema therapy.
Oh, yeah.
These are not beginners. These are not, right? Like, this is not their first, encounter with schema therapy. And yet, Joan and Wendy are pointing out a whole range of ways to kind of tweak the answers, to improve performance a bit, to, consider different things. And this is one of the principles of deliberate practice. And this is how we asked Wendy and Joan to design the book, is to be useful for therapists at a whole range of skill levels. Mm-hmm. And so a beginner might be giving much more rudimentary answers. And what we're seeing is experienced therapists can benefit from this as well.
It's interesting how, Alex, when you give examples about music, I started thinking, I like to think in music metaphors myself, and I started thinking about empathic confrontation. There's a kind of a musical metaphor in empathic confrontation. And in this criteria, if you think of it as, again, I'll just make this up, this idea of, life can throw some really tough things at us, and these are difficult topics to talk about. And I know that in your life, there were times when, the most painful things were just never really adequately addressed. You were shut down. But, so if you can think of here's the opening line, right? Here's the and, here's the but, and the but is what's going to cover that third criteria about other ways of doing this and why it's so important to do so.
Right. And getting that nuance, right? The whole melody, right? It requires practice, exactly. Right? Yeah. Should we do a different client statement?
I don't know if you're going to go on to this one, but I'm just noticing the one from Ian that covers everything.
I was going to do that one next. Let me read it out loud so everyone can hear it. I noticed that you seem to be disoriented and blank when thinking about how you didn't feel loved as a child. Mm-hmm. I wonder if this is the way that you coped when you felt that way as a child too. What would be the benefit of maintaining awareness of your feelings and being able to communicate them? I wonder if this would allow you to feel heard and understood by others.
Mm-hmm. Yeah, it's good. It's good. Again, the wondering could be a little more definitive, but if it's, again, assessment and you're sorting it out and you're still trying to, build that bond with the client, then I love the wondering, for developing just a greater sense of what feels right.
So this is a topic that seems to be coming up repeatedly, is this kind of subtle decision point about when to wonder and when to be directive, for lack of a better word. And it sounds like this comes up, frequently for therapists, and this could be something that you could focus on in deliberate practices, that question. And you could do multiple exercises focusing on that question.
Yeah, because when you know someone, your empathy is already there. It doesn't mean you're absolutely right. You can say, I know you to be someone who ... and I'm wondering if that's what's happening right now, right? If you don't know, then you're just wondering because you don't know for sure yet.
Now, I've got a question I'd like to ask both of you. Is we found when training supervisors in deliberate practice that a lot of times there's this dynamic that can emerge where the trainee or the therapist is sometimes hesitant to be directive because of their own inner process, right? Their own countertransference or whatever reaction they're having. Mm-hmm. And then the supervisor gets hesitant as almost like a parallel process. I'm wondering, does that emerge in schema therapy training? And if so, how do you address that?
It certainly can. And I think that's why we also in schema therapy training focus on therapists being able to notice their own activation of schemas and their own triggering of modes. But I think, too, the idea of being overly polite is sometimes involved also for therapists, and that kind of hesitancy. Although, as you go further in the work, you're likely to be empathically confronting coping modes over and over and over and over again. So I think that idea that in assessment we might wonder, and as we identify it more and the patient also understands it, we can be more definite. And at a later point, we might say, I'm concerned that every time we start to talk about how you felt unloved as a child, your mind goes completely blank and it prevents, so on and so forth. Yeah. And this does come up a lot.
Yeah.
I think that sometimes the client's avoidance can trigger the therapist's avoidance and trigger the supervisor's avoidance. And it's something we do look at a lot in schema therapy supervision.
Yeah. Or the client's anger and criticalness can trigger that too.
Yeah.
And so it's why we do spend some time working on, the sturdying of oneself as a therapist. And that means having to dive into the deep, dark waters of our own schemas and modes.
Mm. And do you think deliberate practice could help supervisors with that, almost like help supervisors learn to kind of be more sturdy in themselves and provide the corrective feedback and find that balance between, not being too polite and not being too disciplinary?
I think seeing the criteria is helpful to me as a supervisor, reminding me of what's really important here that we need to address. And I think that could help supervisors.
And I think getting the patient feedback helps a lot too. So being sure to get, again, I think that's something that will be so critically helpful, is to get that patient feedback where the person either playing the patient or the actual patient, well, in this case, playing the patient because we're practicing, right, can say, I really liked your tone of voice, but there's something about your hesitancy that made it hard for me to feel really connected to you, right?
Yeah,
really
or safe, maybe.
Or safe, or like you understood. I feel like you really care about me, but the words just aren't making me feel like you're really understanding me.
Just realized an interesting parallel here, because supervisors and trainers need to do a form of empathic confrontation with trainees and supervisees, where you're pointing out very directly, I like this, but I don't think that other thing is going to help you, right? Exactly. And having that sturdiness to be very direct with concrete feedback is hard for a lot of supervisors, right?
Oh, yeah.
And we look at that in the supervisor training that's required for people to become schema therapy supervisors.
Yeah.
You know that, Robin. I see Robin sitting there.
Yeah.
We're running out of time. Can I read one last one?
Yeah.
This is from Sevenk. I see that when there's a touch of your lonely side, the detached part is emerging to cut off the difficult emotion. I know that you had to learn this in your childhood when your parents left you alone instead of comforting and validating your feelings. But it is now preventing you to reach out to your need to connect with others. It is also an obstacle for me to reach your needs and find out ways together to increase connection in your life. Let's focus on your needs for a while.
I love that. I actually really, really love that. I think that's great.
I'm reading it over again too.
Yeah, I am too. Yeah. I'm reading it over too, and sure. I'm focusing now. If everyone was looking at this, think about the criteria as you're looking at it, and see how she is able to attend to each criteria in going through this. Makes a suggestion, sees the cost of the mode and how it's a problem. Right, makes the link in criteria 2, opens it with an awareness of the emergence of this mode and the lonely side. That probably
for some trainees who have never done the skill, they might actually need to practice these criteria kind of in isolation,
one at
a time, right?
Yeah. That's part of the skill of schema therapy, is you're interweaving kind of multiple skills in a very responsive way, right?
Yeah, and that's coming through with some of these examples. And I think when we were writing the book, we were being very specific to kind of isolate the pieces. But what we have here from an experienced schema therapist and trainer is that interweaving. Yeah.
Which is fine. You
So
can have interweaving because all criteria are being met.
Yeah. Yeah. And we kind of argued a little bit about that, I think, in terms of the isolation that you guys, as our editors, were getting us to highlight. You know, say, well, but we have to put this one first. It's a little artificial. Yeah, we saw the point.
Sure. This is, and speaking of which, so Eugenia asked a question in the chat, which I don't want to get to right now because I think it takes us a little ways away from where we're at. But I do want to highlight this, which is, this is one of the principles of deliberate practice, is we maintain a focus. And naturally, because therapy is infinitely complex, there's going to be other questions that come up, right? Like if we asked everyone here for a question, we could get 100 questions, you know, like that, right? And they'd all be very meaningful questions. But this is one of the things we found our supervisors, when we're training them in deliberate practice, this is one of the hardest deliberate practice skills to pick up, is to maintain focus, because that's what lets us rehearse multiple times and move the skills into muscle memory, as we've been talking about before. And so we could sit here, I mean, for another hour, easy, and just be rehearsing just this skill. Boom, boom, boom. And I guarantee you, Wendy and Joan would have great feedback, you know, like really like good corrective feedback for each response for an hour plus. So we're starting to run out of time here. Let's see, should we do one more? Let's do one more. Let's scroll down all the way to the bottom, and there's one from Ite. I'm sorry if I'm not pronouncing people's names right. I'm trying. Wow, it can feel so painful to feel unloved and unseen. I can wholeheartedly relate. But let's look what happened here. You felt pain, and then the part of you knows how to detach, was immediately and urgently called upon and showed up. That part of you that you know since you were a little girl, but when it showed up, it didn't allow you to feel the pain. But we already, that by blocking your sense of pain, we already know that by blocking your sense of pain, you are also blocking being aware of your pressing need for connection, recognition. And this just perpetuates your loneliness. Is it so important that you can find some other way to face that pain? Can we think together of other ideas?
I'm not sure for the third criteria. I'm not sure that the comment about facing the pain, let's see. I'm looking back at the specifics of, okay, it blocks your being aware of your pressing need. Okay, can we look at the pain to think of some other ideas? I would probably just want a little bit more specificity in the last sentence, but overall, I think it's hitting the criteria.
Like what, Joan, for the last sentence?
Well, I was trying not to be repetitive, and okay.
That's okay.
Blocking. Could you stay aware just for a minute or two right now of what you were feeling before you cut off?
Great. Yeah. Great. This seems to be a theme, is that more specificity is better. Is that roughly accurate?
In the way I tend to come up with interventions.
Yeah, I like that too. I think first of all, I think it's actually very well done. But that last part too, for me, I agree with Joan. I think it's said so nicely there. We already, by blocking your sense of pain, you're blocking being aware of your pressing need for connection and recognition. That's really nice, right? Because there's the cost to this mode being present. And then just really simply, maybe we could just stay with it for a moment here, you and I together.
Just that.
Room, right?
Yeah. Which is the same thing I was going for.
Exactly.
That's the piece that I think is important.
Yeah.
I think in a way, my focus on specificity comes from working with very dissociative, detached people
Right.
who would get lost in a long
Right.
answer,
Mhm.
and need more definite, even abrupt kind of things to respond to. It does depend so much also on the patient.
Right.
On the patient, yeah. And what
Great.
you're trying to achieve, because if you look at our skills for setting limits, they're going to look very different.
Right.
Mhm.
Great. We're unfortunately out of time. I think we could do this for all day if we had time. I would like to thank you both, Wendy and Joan, for joining us. This has been a great webinar, and I'd like to especially thank all the participants who courageously tried the exercise and put your answers in the chat.
Indeed.
Yeah,
This
really
is,
good responses.
Yeah, great
Really,
responses.
Yeah.
really good responses you came up with.
Yeah.
Yeah,
All of
Alex
you.
and I are always so impressed by the schema therapy community. It's so worldwide, so engaged, so enthusiastic. It has just been great.
Yeah.
So-
Thanks for having us. Thanks everyone for joining us today.
Thank
It's
you.
really been a pleasure.